This is the next one of the joint PRSB BCS Health and Care Health Informatics webinars, Health Informatics Standards webinars. I'm Mike Anderson from BCS Health and Care. I'm joined by my colleague from the PRSB, Charlie McKay, and it's a great privilege to introduce Professor Maureen Baker and Stuart Harrison, who are going to give the talk today on how we ensure digital systems in healthcare are safe. We're recording this, and we're also going to be putting the slides into the public domain as soon as possible. We'll put the link to that into the chat. We'll be hearing from Maureen and Stuart for about 40 minutes, and then we'll have a Q&A session at the end. If you want to put comments, questions, etc., into the chat, we'll go through those at the end and pick out the ones that have come up most or that are of the highest interest. So I won't delay any further. I'll hand over to Stuart and Maureen, and I should just say before I do that, thank you very much indeed for agreeing to do this talk. We are very privileged to have you here, given your leadership positions and all you've done in the safety area, which I know you've been doing for a very long time. So welcome and thank you. Over to you.
Well, thank you very much, Mike. And Stuart and I have agreed that I'll kick off. So my name is Maureen Baker. I am the chair of PRSB, Professional Record Standards Body, and I'm a GP by background. I have indeed a long interest in digital patient safety, actually starting from about 20 years ago, so it's a very long time. And the background to that is that I had been in the National Patient Safety Agency. This was at the time when the ill-fated National Programme for IT was being set up. And from the NPSA perspective, there didn't seem to be much of a focus on patient safety. So cut a long story short, I actually got seconded in at the time to what then became NHS Connecting for Health, with a remit to set up a formal safety management system. And of course, you know, what did I know about safety management system? Next to nothing at the time. But in the wisdom, I was paired up with some safety engineers, and we evolved the safety management system for Connecting for Health on the basis of jointly having clinical and safety engineering input. And a large part of that clearly is about standards. You know, anyone who's got any sort of engineering background, any type of engineering background, works to standards. And so that's really what we're, I think, going to talk about today. Over the years, you know, I was clinical director of patient safety at Connecting for Health. I've also worked with Royal College of GPs. I became chair of the RCGP, and following that, I actually joined PRSB, largely because of the standards focus and my belief that standards are an essential part of the safety infrastructure. I'm delighted this afternoon to be presenting with Stuart, who is my old friend and colleague, and hopefully we'll give you a flavour of the sort of need for both the clinical and the structured safety approach. Right, so I think that was all I wanted to say about the introduction. So Stuart's kindly driving our slides, so as has always been the case. So if you don't mind, Stuart, we'll move on to the first one. So just a few sort of introductory slides about patient safety. And fortunately, you know, most healthcare is safe and most healthcare is high quality, but things can go wrong in healthcare, things can go wrong in technology. And when you actually look at what goes wrong in health, it can be quite alarming. I mean, there's huge potential for things to go wrong. So, you know, just in the NHS, we're talking about 1.5 million episodes of care every day. You know, about 1 million of those are in general practice. The volume of prescriptions generated through general practice is huge, at least 1 billion prescriptions quite possibly more now. And with that amount, you don't need very many things to go wrong before actually quite a considerable number of people are affected. So the potential for harm for patients, even just related to the volume of transactions, is considerable. And that's one reason why, you know, we have to try as hard as we can and use our tools like our digital tools to try and promote patient safety, to try and support the healthcare professionals who are providing care. If we move on, so these are just a few of the issues that we have in the NHS. We've got considerable workforce problems, although some aspects of our provision of care through the NHS, such as equity, are excellent. Other aspects, such as outcomes in very important areas like cancer or heart disease, are not as good as they should be. And there's also an issue of diagnostic errors, which is common patient safety errors seen worldwide, and we're afflicted by those as most other people are. Round about, it's always often been estimated that round about 10% of healthcare encounters will have some error. The vast majority of those are minor errors that result in no or very little harm, but you know, clearly there are some very significant errors that have very major effects on people's life and the quality of life. So the next slide, please. So we do have in the NHS a patient safety strategy, and you know, this is a quote from that. If we were able to maximise our patient safety opportunities, it really would have a profound effect on outcomes, on the quality of care that people receive. And digital health clearly has a huge part to play. I mean, I mentioned earlier the 1 billion prescriptions from general practice, and this is just, I mean, I know it's stating the obvious, but when I joined general practice a long time ago, we had handwritten prescriptions, and the number of errors through illegible handwriting was considerable. Funnily enough, or not funnily enough, there was never a study done to show the benefit, the safety benefit of electronic prescribing. But you just have to think about it. It's huge. It's a huge benefit from electronic prescribing, just from the point of view of taking out the illegibility issues. And so I always point to that as one of the clearest examples of, I mean, and it's very simple, you take out the illegible handwriting through electronic prescriptions and your safety benefit is huge. Having said that, I'm always astonished that across the NHS, particularly in the acute sector, we still don't have consistent and widespread electronic prescribing. So the illegibility errors are still around. Next slide, please. So don't need to tell you guys this, there are so many opportunities that digital methods can give us to improve patient safety. I am frustrated though over the years that improvements or digital ways of doing things are introduced with a whole range of benefits, maybe efficiency, time saved, communication, all sorts of benefits. But I often think that when new technologies are introduced, there hasn't been enough thought as to how safety can be maximised. through the introduction of technology, and or even not introducing, sort of implementing and having sort of widespread access. And I do think that's something that as a community we could think a bit harder about. So next one, please, Stuart. I'm not going to go on too much longer. So there's all sorts of possibilities. Stuart's going to talk a little bit about AI, which personally I think has got huge potential. We do have to be careful though, because colleagues often say to us, don't talk to me about AI, I can't access a computer. I've got to stand in line to get one, or I can't get one at all. But just because, you know, some things are poorly done doesn't mean that we shouldn't look to see what the opportunities and the potentials are of emerging technologies. And I would urge we should really be thinking about how these can be maximised to improve patient safety. Next one, please. So, discussed a few things, and I think we're coming back basically to, you know, some basic things: interoperability, standards. In PRSB, we have a suite of standards around transfer of care, and interfaces across medical systems. So the interface between primary care and acute, the interface between ambulance and acute, or mental health, primary care, all these interfaces are opportunities for things to go wrong. You know, the interface of care is potentially one of the most dangerous places you can be as a patient. If your drugs are wrong, if investigations aren't followed up, if the wrong information is transmitted, there's a whole bunch of reasons why things can go wrong at interfaces of care. And the whole point of the transfer of care standards is to try to minimise the opportunities for things to go wrong. And one of our frustrations is that, you know, these standards, and indeed lots of other standards, are out there, but aren't, you know, consistently, never mind universally, applied in ways that could promote patient safety. And some of that might be to do with, you know, some of the things we're saying there. We've not got sufficiently good interoperability. Maybe staff haven't got the right skills. Personally, I think there's also something about one sector just works for what works for them, and they don't think about the next bit down the line. So, you know, as a GP, what does a GP need? What information does the GP need to know? And how do you transmit that information in the best way to the GP so that they can pick up the care of a patient who's been discharged from hospital? It's not enough just to do your job in one sector and not think about the best way to hand the care over to another. And a lot of the work we do in PRSB is about trying to have standards and ways of caring that will, you know, take this variability out of the system. Next one, please. So we think our standard, I think of PRSB standards as essential safety infrastructure. That's why I joined PRSB. That's why I think our work is really important. These things are fairly obvious. You know, information unambiguous. When we say something, we all mean the same thing. The PRSB has a standard in digital care and support planning, which was produced, I think, about 3 or 4 years ago. But at the time that standard was put together, there was no agreed consensus on care plan. What one person or one sector meant by a care plan was not necessarily what somebody else thought was. And yet, you know, we structure so much of care, particularly integrated care, particularly care for elderly people or people with multiple comorbidities. The care plan's essential. So we really should all mean the same thing when we talk about a care plan, in my view. Okay, next one. So safety benefits. These are a sample, but one of the things we try to do with our standards is to think about how, as the standards approach and the PRSB standards can give us this maximum safety premium. And the sort of things we've got down there are, reasonably obvious, but if you don't think about them in a structured, established way, then things can get missed. Or what one sector thinks it's doing is not necessarily the same as another sector. So all of these things can be benefits, safety benefits of PRSB standards. We think there are other benefits as well, but we're concentrating on safety perspective just now. Next one. So I think I've said, in my introduction really, that we need to really think about maximising the benefit of our technologies. We also need to try to ensure that when we do introduce a technology, we are not introducing new problems. So there's no point in solving one set of problems, like for instance, illegible handwriting, and introducing new problems with electronic prescribing, such as errors from pick lists or mapping errors, or all sorts of potential errors that you can have. So we need to think about what benefit we're getting from safety when we introduce something, and how do we do as much as we can to avoid the new technology creating a new set of safety problems. Okay, there's a bit there about regulators and regulations and standards. Again, this comes back to sort of the need to have a standards approach in our work. And I would just say that actually 20 years ago, there was no regulation of health IT. There were no standards. It wasn't there. And, we've come a long way, but there's still a long way to go. So I think that's just about me finished. If we go on to the next one. Yeah, so there's some contact details for us. I'm also at Maureen PRSB on Twitter, but feel free to get in touch with us anytime. And Stuart, over to you. I'm sorry, I've only saved you 2 minutes, but you can have them.
That's okay. Thanks, Maureen. I think there'll be a few people that know me. For those that don't, as obvious, Maureen's given me a nice introduction. I think for a large part of my career in the NHS, I've been Maureen's personal assistant, and I'm glad to be doing that now. Again, after so much time, I missed that. And I work now privately for an organisation called Ethos. Left the NHS in 2018 and continue to do this clinical safety stuff and regulatory stuff and voluntary standards based stuff as well. So I'm a bit of a standards geek in that regard. So what I've done here is I've taken the webinar objective when there's an assumption here that people that are dialing into this webinar have got a limited or basic foundational understanding of digital health and standards and safety. And so that's where this part of the webinar will kind of leverage that kind of information. And I've looked at the questions in terms of how do we ensure digital systems affairs from a profession perspective and also from an organisational perspective. Now, I've worked within this industry for quite many years, and splitting it up into this particular grouping is quite effective to give you some questions and answers that align to this webinar objective and the heading. So number one, if you're working in this industry from a professional perspective, regardless of whether you're NHS or you work for a manufacturer of health software or medical devices, you've really not got to be familiar with your market and the industry in which you operate. And these are common sense things. due to the backstory of this being PRSB and BCS sponsored event, it's common sense that we should seek guidance around standards and any other strategic policies and so on in the health industry within the UK. And it provides you with good leverage for and a good transition for other markets, whether you work in another sector, whether you work in another market in another country, and so on. And understanding what your responsibility is, what are you on the hook for? For example, if you're a technician and you're supporting a product perspective from a safety perspective or security perspective, then you have a role to play in making sure that a system is safe, or making sure that it is used or implemented in a safe way. And similarly, if you're a clinician and you take a position as for example, clinical safety officer, clinical lead, medical device safety officer, then you've got to understand your obligations and your remits, and then you can operate with those boundaries in place and grow your knowledge. The rest is not going to be death by PowerPoint. It's going to be a little bit around collaboration and being proactive. From a clinical safety perspective, I see quite a number of different communities being set up, both within NHS forums and otherwise. And these communities are good. I wish we had those. I wish me and Maureen had those back in the day, because we'd certainly be a lot further down the line from a digital clinical safety perspective than we are now. My only caution in this context is be careful what you share. So you can share examples that are anonymized for certain issues around consent, around should this be assessed, what kind of assessment is it, and how have you made it safe. Be very, very cautious on intellectual property of various organisations, regardless of whether or not you think non-disclosures are useful or correct, and so on. Be a little bit prudent, because if you carte blanche share everything, that's not proactive, and that's not helpful. It isn't insightful. Not in my opinion. I think you should be a little bit more considered in what you share. And things around, can I trust you? From where I'm coming from is, if I'm working within any organisation and I know my role and responsibility, and I'm looking at stakeholders and other people who are partly contributing to the overall safety of a particular product, can you trust them? How do they behave? Are they more mercenary? Are they just worried about the contract, the finance, ticking a particular box in terms of compliance to a standard? And those behaviours are not necessarily wholly negative, but they allow you to scene set and say, right, okay, I know how you operate, I know whether I can trust you, and I know what your raison d'etre is across this particular piece of work. And it just allows you to do your role and perform in a nice way. If you look at some of the stuff I've put together here in this webinar, I'm not going to go through all of the slides. There's a lot of it is informative and references that will be towards the back end. And that aligns to, do I know enough? A lot of people that are new in the game in this, from a technical, from an innovator, from a startup, or from a clinical perspective, it takes time to learn this stuff. There are so many people that sell snake oil in terms of their expertise. There are so many documents out there, so many different organisations. So just take your time and just start small and grow your expertise and grow your knowledge. And from a professional perspective, that will ensure and that will contribute to ensuring digital systems are safe. From an organisational perspective, there is a lot of subjectivity from some compliance positions and some claims that products are fit for purpose. And one of the easiest ways, and probably in my perspective, the only way to avoid that subjectivity, is comply with the industry standards, because that allows you a really firm foundation to demonstrate that your product is fit for purpose, that your product is secure, is safe, and so on and so on. Have I assessed it correctly? Well, this falls in line with a number of different facets around safety, in so much as anybody can claim a product is safe, but you've got to demonstrate it by evidence. And let's face it, that the evidence is quite varied across the industry currently. We are seeing some stronger and higher quality compliance efforts across the different types of products that are out there and organisations, both NHS and otherwise. But my simplest and most assured recommendation is keep it plain English, demonstrate the evidence, demonstrate the safety of the product by evidence, good quality evidence, and be very, very collaborative with either the stakeholders in the group, with the clients that you're buying the system from, or with your customer who is buying the system from you. One final point to note on this, and not labouring the point, is try to filter out who's an expert and who isn't. And you can probably find your own nice ways of, from a personal perspective, on who you'd want to talk to in the street or in a cafe or whatever, adopt a similar position. You can usually sniff people out who may proclaim to be experts and not actually have the evidence to back that up. From a regulatory perspective, we're going to be talking about standards. It's part of this webinar. A regulatory strategy for me is key for any product, any company that's looking to either move into this industry, the health industry, or a startup that's looking to start working in this industry. And a regulatory strategy will allow you to apply just the amount of diligence, safety in this perspective, in this particular example, as is reasonable and is required, and from a return on an investment perspective, it's adequate. Don't go running a million miles away from trying to comply with every standard that's under the sun, because you might not necessarily need it, or even fall within scope of that standard within the early days of developing your system. Another problem that we've got within the industry around working towards digitally safe products in a health context is terminologies. Anyone that's a standards geek, I know that some of the guys that are helping to coordinate and run this webinar session will probably agree with me, including clinical colleagues that have dialed in. Terminologies have got to be the same so we can talk the same language and we can aspire to get to the right objectives from any of these domains. And these are the three domains that largely the health industry operate. This diagram's from an international standard. I had the pleasure of working with some really bright people within NHS Digital at the time to develop this, the 80,000 series of standards. Safety, security and effectiveness have all got a different dependencies on each other. They all have, and it covers quite a large amount of good quality to put forward a good safety claim. Not going to talk about DTAC too much, but what I'd like to signpost is the label to enable work that one of my colleagues on this webinar is part of. From a DTAC perspective, you can see the different domains of safety, effectiveness and security are all interweaved within the 5 domains. And it's also moving towards a really nice, usable way of being able to trust healthcare applications, which take up probably over 70% of the market, and low and high risk products in that regard. So again, we're looking at standardizing, we're looking at making standards more usable, and all of this points to how good quality and how good quality safety claims can be made. I'm going to breeze through these a little bit quicker because these are informative slides. From a commissioning perspective, I've put together the underlying text, hyperlinks to NHS England's commitment that remains the same post-pandemic from a digital context in terms of interoperability and the way these systems work together. And again, I've split these up from a security, from an evidence or effectiveness perspective, and core principles. A nice real evidence framework is firmly sat underneath the effectiveness domain, and there have been some really significant updates since this initially got revamped or published in the probably around 2018 or slightly earlier, and the regular updates on NICE from an arm's length body to do some really great stuff, particularly from an AI perspective, very recent. And that slides towards the end of this, and it's a completely different subject. But this area around effectiveness measures and whether or not product meets the original outcomes from a clinical perspective, this is all really good stuff and links to that age-old objective from a clinical perspective with systems. As an informative piece as well, Reform and the King's Fund, as industry bodies, do some really great stuff from infographics and interactive infographics. The data-driven healthcare work here is a nice interactive roadmap, and there's lots of links there to different arm's length bodies or regulators who are responsible for data and aspects of data, clinical trials, pilots, and so on, that are part of the regulatory process with a particular product, all the way through from start to end. Very informative and nice, really good icebreaker into this subject. And in terms of what do we do if we're working on a product or working in an area that is completely new, and I think probably about 5 years we could have said that with AI. And this is where an equivalence measure comes into it. And this is where good quality and safety can be derived from looking at what other industries do, and just tapping into that AI perspective. AI has been around in other industries for quite a long time, longer than the NHS specifically has been using it. And so some of the work in terms of new standards and updated standards and guidance and best practice has been taken from these industries: aerospace, defence, rail, automotive, and automation. And it just shows how connected the data is across the health IT or health software landscape. This is an old diagram, so if anybody knows me, they'll know that this gets popped up in anything that I do. I should make it more beautiful, but it's simple and it's within its context. So this was done when software as a medical device was raising its head and becoming quite prolific, probably around 5 or 6 years ago. And it just shows now a vast majority of apps and clinical decision support systems that are software focused. They're not embedded into traditional physical medical devices. The larger volume of the market these days, and that's why NHS Digital and colleagues were quite insightful in updating their standards, and the DTAC follows with this. There has been some recent debates around LinkedIn on this. In my opinion, it should be software as a medical device only and not traditional medical devices. It's another topic for another time that could probably take another hour. But that's based on experience and based on consensus of a number of people within the industry. There's a nice little infographic here around the clinical safety standards. We can't do anything around standards and safety without referencing these, but you're not going to get anything from me out of this. It's quite nice to say that it's well known and it's interlinked. Another thing that would help an organisation, whether it be NHS or otherwise, to manage safety and quality of the product is some form of quality management system. And what I've done here is I've distilled a pictorial view of the requirements of clinical safety standards. And if you fold this into a management system structure, which everybody should be familiar with, either from a risk management, quality management, or information security, then it allows you to systematically and consistently apply various objectives aligned to requirements in a consistent way. And this is all common sense and shouldn't be surprising. The management system structures could be literally 2 or 3 pages and a handful of processes if you're a company of 2 or 3 people, to being a large system, a bespoke system if the company's a lot bigger. So I'm going to kind of wind up this and breeze through a few slides now. finding the best information to grow your experience and learn a little bit more. I've listed some here. What is a medical device? Extracted this from the legislation and the regulations. I love this interactive PDF that the MHRA consistently update. They've got a really great team these days that are very active in their own space around software and a medical device, faster regulation, more intuitive from a UK perspective. This has got more guidance now in the appendices, and it's great. From an AI perspective, there's probably going to be some AI questions, but nice. This group of arm's length bodies have done something great here around AI regulation from a service perspective. So that's a provision of a service. Maybe, for example, waiting times, early sites of hospital infection and so on. So from a service perspective, and they're very synergist with these two areas. So the CTA, an American industry body, that's nice for any AI techies and any geeks in that perspective. A lot of content in this particular standard or industry standard is also in place within the British standard that's just come out last month around quality in the use of AI in healthcare, and that covers both NHS and manufacturers. There's some really good, bright organisations that have been in the committee to develop that particular standard, and it covers some core domains, and those core domains are very, very similar, if not equivalent or the same as when I first put up those diagrams: safety, effectiveness and security. So those are things that one could look at and have a look at to see, update their knowledge and continuously grow in this area. Now, from an industry's perspective and a market perspective, the industry is growing massively, and I think the compounded annual growth percentage is double figures. It's between 30% and 25%, depending on which market sector you're looking at. So we're in a luxury position. It's not down to single figures or low single figures where other industries are, not so much defence, but maybe consumer or light commercial products, and more competitive. So you have to be more mercenary operating in those industries. Within healthcare, we don't have to align to those mercenary positions. So now we can be a little bit more proactive, we can be more collaborative, and we can help, and we can help others. Sure, and that's probably the major message that I can provide is alignment to the standards is great. Alignment to and sharing best practice is even better. Having awareness of where to find things, but when you've tackled the problem, maybe AI, share it, anonymize it and share it, because then we can start tackling some of the other things. When I look back at my time in the NHS, 2018 when I left was a little bit traumatic for me. I look forward from 2018 and I see not a lot has been done from a digital clinical safety perspective, except for the last couple of years. If we'd have had, me and Maureen, the same investment that cybersecurity had back in the day, or at least 10 years ago, we wouldn't be in this position that we're in now, in terms of still talking about it, still trying to share good practice. And for me, I think that's probably the best message that I can probably give. Share, collaborate, and be a little bit more proactive, and don't be frightened. So that's it from my contribution. I'll stop sharing my slides.
Excellent.
I'll leave myself to the mercy of Mike and Charlie.
Right, well, thank you very much indeed, Maureen and Stuart. That was excellent. And there's a whole wealth of information there that people will want to follow up. As I said at the beginning, the slides will be going online shortly after this, and the recording will also be going online, but that will take a little bit longer. So we're going to have a bit of Q&A now. Charlie, my colleague from PRSB, has been looking at the chat, and I think is going to have quite a challenge picking out the questions to answer or the issues to take up, because there have been quite a lot of them. Charlie, over to you.
Well, very kind of you. And I'll starting at the top, because that's not a bad place to start. There's a question from Tim Benson. There are two types of standard: minimum standards such as in safety and exact standards such as in interoperability. Both are very important. They need different names. So do you believe that? And if so, any suggestions?
I don't mind jumping into this one.
I think that's definitely one for you, Stuart.
Yeah. So I kind of agree, but if you take yourself from a position of walking into this industry with zero experience, then the terminologies that we need to provide, I think we should form safety, security, and effectiveness. I think interoperability cuts through at least two of those domains. And so once you start working into the standards area, you'll probably start confusing the hell out of yourself with information security, cyber security, and information governance, consent, trust, and so on. It's probably not the answer that you're looking for, but I would say at this stage and for this group, I would say no. I would say from a safety perspective, we're looking at safety, security contributes to that, and effectiveness proves it. And interoperability is one of the golden threads that fall through many of these standards.
And I'm guessing that the next question, which is about whether you're talking about user level interoperability or system level interoperability, you'd say that both apply, and that's true.
I would, yes. So it depends on which lens that you're looking through or which hat you're wearing, whichever adjective you want to use. So if I'm looking at the safety of the product, so from a regulatory perspective, the be all and end all is the safety of the product. And what contributes to the safety of the product are security measures, and it's got to be less vulnerable to exploitation or attack. It's also got to be safe from a usability perspective, human factors, accessibility. And so those are one of the many golden threads that cut through many of these domains.
But if I could just come in there, I think that question was put into the chat when Maureen was talking about the interfaces between different care organisations, so from ambulance to hospital or for GP to hospital. And I don't know if you want to add anything there, Maureen, but I mean, it is about the interface between clinical systems as well as IT systems.
Absolutely. And from a clinical point of view, and I'm not technical, and Stuart will totally back me up on that one, but from a clinical point of view, I always think about having the right information, getting to the right people at the right time in order to provide safe and effective patient care. And part of that's human, part of that's the systems we use, part of that's the structure that the systems are set within. And it goes back to my point about not necessarily, just thinking about your organisation. So take something like the NHS number standard, which has been around forever and has been mandated to the service at least 4 times, to my knowledge, in the last 20 years, and still isn't consistently applied. And, not wanting to denigrate particular sectors, but certainly when I used to work in National Patient Safety Agency, you would have people say, well, we need to do all the work, people in the hospital, we need to do all the work and put in all the investment for the benefit to come through to general practice. And I just think that's such a siloed way of looking at things. What we jointly want is the patient to get the best care and have the best care experience. And, your responsibility shouldn't, it doesn't just sit within the confines of your institution. We haven't been good enough in the NHS at taking a whole system perspective. There's things to do with funding and, responsibilities that get in the way of that. But that's fundamentally what needs to happen.
Thanks, Maureen. Charlie, next one. I think you may be
I muted myself because of a vehicle going past. But there's a request from Mary Hawking for the shared record professional guidance to be republished and made available. So if anyone knows how to do that, but maybe we'll follow that one up offline.
I'd write in, Mary, just write to the chair or get the health informatics group to flag it up. The college is usually pretty responsive to requests from members. Maybe Chris knows more.
Yeah, just to respond, thanks, Maureen. Respond as an officer of the college. That document was from 2009, which is why you don't currently see it on the RCGP website as is presented. Every page and every document on the website was reviewed in terms of a recent refresh, and there's a large amount of content that was stood down. But you can, it's a straightforward process to contact the college to flag up a document that you feel has some relevance. Although with any and it was a report rather than guidance, so any guidance from 2009 would quite rightly have been removed. But I say with the report with his historical significance, you can argue the case, although there are other sites that might be better suited to historical documents. Thanks.
Thank you for that. And then another question from Leon Lindsay. At the moment, there's inconsistency in suppliers' responses regarding compliance with safety standards, DTAC, Cyber Essentials, and DCV standards. With the increasing use of AI, think that AMLAS framework needs to be included in the safety standards and support. So there's kind of a general question about how do we make it easier and more transparent. And we've had a few other questions in a similar vein. So really, how can we make it easier to navigate this space with so many?
I could probably take this. So, and this is from personal experience. So, the good works that NHS Digital did from the early days up to probably 2015 to 2018 was massively underfunded, and like many other parts of the NHS, National Cyber Security Centre was set up as a result of WannaCry. A significant amount of investment, and you can see how information security and cyber security awareness has increased, and the familiarity of the subject, it's on many people's agenda, including the complexity of AI in that domain, has improved and matured through investment. It doesn't take a lot of money to invest in the safety perspective, from a safety perspective, because those who work in the area, from my perspective and from my experience, are probably true core NHS people who do it for a large percent of the time, from a professional perspective, for the love, and not necessarily for the reward and the money. So I think the way to improve it would be to significantly invest in NHS, what is now NHS England's clinical safety team, and to allow them to provide guidance, training, or offload the training into the industry. Because when I was around, I was asked, when I first started the training, I was asked by the finance director within NHSD, is why do we need it? Why do we need to train people around the clinical safety standards, believe it or not? And the decision was, well, yeah, NHS Digital can run it for a few years until the industry pick it up. And that tends to be a lot of the ways that the NHS work at the moment. You do bare minimum and let the industry take over, but that always isn't, and from a clinical safety perspective, isn't the right way to go. I think a core set of subject matter experts, that there are quite a few really good people in the old NHSD clinical safety space, and invest in them and grow it in a similar way to how cyber security has grown, and you'd really see some results.
I come in here to say that one area we lack is a formal accreditation scheme. So, you know, why isn't there a kite mark that suppliers into the NHS meet the standards for safety, security and effectiveness. Now, many of you will know that PRSB has a standards partnership scheme with system suppliers. That is around, obviously, PRSB standards. And we, as part of that partnership scheme, there is an accreditation side to that. But as far as I know, and out with like ISO standards and things like that, that there isn't any other formal accreditation stroke kite mark. And you kind of have to say, why not? Wouldn't that be much easier, much simpler for healthcare organisations, NHS and indeed others, to invest in products that they know are fit for purpose from the perspective of safety, security and effectiveness?
And I think that almost pre-answers the question, but I think it's probably useful to ask it around this observation from Kimberly Dawson, that the hardest thing currently is getting suppliers to share or do safety cases, along with them saying that other CSOs have not asked for DCB 0129s from them. So how do we make sure that we're all working on the same safety framework? And I think maybe that, a certification scheme would be one approach. But Stuart,
originally when the SHAs were shut down and NHS England was set up, there were some frameworks, some commissioning frameworks set up, and myself and Maureen worked on around about 7 primary care, IT commissioning, dentistry, and a few others. Within those frameworks, there were template procurement contracts that included the requirements for several things, 2 of which were the clinical safety requirements, and these are called schedules in NHS law. One of the schedules was, are you compliant in the standards, yes or no? And the other one was, if you're not compliant, then factor that into your tender, your application, and jointly do the work with your NHS client. I'm paraphrasing, but the reason behind that was not to ostracize the company because they didn't immediately comply, but it allowed them still to get onto a framework or tender their application, because some applications may be the best in the world and operate really well, but don't have the compliances that you're looking for. So that risk versus benefit decision that is always made across many domains. So I think that the procurement frameworks and increase the procurement intelligence is one of the major solutions to this. So those that are tendering or working in the tendering, assessing and reviewing things, they should have a foundational understanding of what these things are that they're assessing, and some consistency in that manner.
Sorry, Stuart. Get back to the point about being told by suppliers that other clinical safety officers don't ask for a safety case. I'm tempted to say, well, they would say that, wouldn't they? Who's going to disprove it? But the whole point of having a clinical safety officer in a trust or a provider organisation is to sort of manage this passing, what we used to call passing the safety baton from the supplier to the clinical setting, and it's structured around the safety case. Now, I mean, I would just challenge that in that position, because you could say, well, those CSOs, if they exist, aren't doing their jobs, and I'm doing mine, and I, as a CSO, am working to DCB 1060, and you should be working to DCB 0129. By the way, I hate standards names. We should come up with letters and numbers. There must be a better way to do it, but anyway.
Yeah, no, I think, and maybe it's going back to Stuart's comment that there needs to be a chunk of drive across the system just to make that normal practice, and reinforcement that it is. I'd like to just pick up finally Brendan O'Brien's comment that the NHS digital training on clinical safety was very helpful, but I'm trying to develop an approach in Scotland which is more an apprenticeship model, consisting of e-learning for background orientation and then working alongside experienced CSC team on an actual CSC. And I think, have you got any sort of reflections on that? Or Brendan, maybe do you want to speak to it?
So it's just part of the context of that is we've found the team we've built in Scotland have all done the NHS digital training, but we've all found it a useful background. And there's a long way from being a useful CSO or CSC between doing that sort of online training, the one day face-to-face. And I suppose that we're now a team that have been doing that for a number of years and covered off clinical safety cases in a large number of the national clinical systems in Scotland. So we're just trying to move more to a model where you would have the equivalent of the NHS digital training, whether it's that or something specific for Scotland, but then more working alongside a team. You get into developing the hazard logs and so on, and the kind of the risk management approaches and so on. And you really only get your stripes when you kind of have walked through one of those and kind of strolled through it, and you realise that the kind of e-learning has given you some useful background, but doesn't really give you the experience, I suppose, to make you competent.
It's providing that central mentoring service. Carry on, Maureen.
Oh, I think that's a great idea. Actually, when we set up the safety training 20 years ago, and some of you guys probably went through it in the early stages, it was a face-to-face course. And part of the value of that, I always felt, was getting your clinicians together with your, technical people, technical departments, or the information governance, just getting people with a different perspective together to think about how you safely do something. And I think that is lost to a certain extent when it's just e-learning, me and the computer. And again, we used to run it as 2 days, and the first part was very much sort of theory, but the second part was sitting down and really working through a safety case or various scenarios, which again you don't get through the the online learning. You need that, I think, but it's not the be all and end all. And anyone who is just sort of starting off as a clinical safety officer will benefit hugely from being able to work with other colleagues, and particularly people with more experience.
Thanks, Maureen. So it's almost 6 o'clock, so I think we'll have to draw it to a close very shortly. Obviously, we could go on for considerably longer. I would say that the FCI might have a network of CSOs, which, if you're not aware of it, might be worth following it up. And I also think, without wishing to stick my neck out too far, that I think there are some opportunities for PRSB and BCS and FCI to get together to see if we can put some pressure on the system to improve some of these shortcomings that we've been talking about. Of course, it really is I can't think how to put this diplomatically, but some of the things we've heard about lack of investment and lack of coordination, I think we might be able to put some pressure on to help with that. So just one other little thing. I think the thing about making this UK-wide is important as well. So for those of you who aren't aware, DCB 0129 and DCB 0160 are actually NHS England standards, and it gets a bit grey outside England. So I think that's all to say about that in particular. I'll just remind you that the slides will be available very shortly on the BCS website, and the recording will follow as soon as possible. And I'd just like to say thank you very much indeed to all of you for attending, but more particularly to Maureen and Stuart for a truly excellent presentation. I think you've advanced the cause of safety in digital systems significantly by doing this today. I really appreciate it, and I think the audience will have done as well. So many thanks. And if you don't mind hanging on for a couple, oh, sorry, Charlie, you wanted to say something?
Only to say this webinar is part of a series, and we're now taking a summer break, but it will start again in September time with another flurry of interesting and exciting topics. So please do keep an eye out for those, publicised through the usual channels through BCS and PRSB.
Yeah, thank you, Charlie. Yes, I should have mentioned that, so that's very much appreciated.